The first tests I will be doing are designed to check the integrity of the collateral ligaments of the elbow. So the first test is assessing the UCL through a valgus test. With the patient's arm in 20 degrees of elbow flexion, I stabilize the humerus and provide a valgus force through his forearm, making sure to compare the involved side to the uninvolved side to assess for excessive laxity or reproducing his pain. So the varus stress test can also be done to assess the LCL in the same starting position of the elbow, providing a varus force through his forearm. Again, comparing the involved side to the uninvolved side, a positive test would be reproducing his radial-sided pain or increased laxity. The next test is called the milking maneuver to assess the UCL. So with the patient's arm in 90 degrees of flexion and his palm up, I'm stabilizing the elbow while pulling his thumb to provide a valgus force. So a positive response would be reproducing his pain. The moving valgus stress test is done to assess the ulnar collateral ligament. So I'm bringing the patient's arm into 90 degrees of abduction and full elbow flexion. I'm going to use my hand to provide a valgus stress at his elbow while gradually straightening his elbow out. So if the patient's pain is reproduced between 70 to 100 degrees of elbow flexion, that would indicate a positive test result. The next series of tests are done to assess for lateral epicondylitis at the elbow. So first, the Cosen's test is going to be done by having the patient make a fist, and I'm going to resist his wrist extension, looking for a reproduction of his complaints, which would be a positive test. So next, the Mills test will be done with the extensors on stretch. So I'm going to straighten his elbow and flex his wrist and fingers, and reproducing his complaints here would also be a positive test. And lastly, I can do the Maudsley's test, which is just going to be resisted middle finger extension distal to the PIP joint. And a positive test result would be reproducing his pain at the tendon for the lateral epicondyle. The bicep squeeze test is done to assess for a rupture of the biceps. So with the patient resting his hand on his thigh at about 80 degrees of elbow flexion, I'm going to come around his muscle belly and squeeze here. Since he has a normal response, there is a slight supination response at his forearm. If the biceps wasn't intact, there would be no motion, indicating a positive test. The elbow flexion test is done to assess for suspected ulnar nerve entrapment within the cubital tunnel. So I have the patient rest his hands up and bent back for about 3 minutes. Reproducing ulnar nerve tingling or paresthesia would be a positive test. The patient can also come up into shoulder abduction to further sensitize the test and assess for any numbness or tingling. The Tinel's test can be done to assess the ulnar nerve at the cubital tunnel. So I'm going to come in, palpate the cubital tunnel here, and I'm going to tap his arm while supporting it, just looking for a reproduction of his complaints, including numbness or paresthesia, which would be a positive response. The pinch grip test is done to assess for nerve involvement of the anterior interosseous nerve. So I ask the patient to make the OK sign by touching his tip of his index finger with the tip of his thumb. He's able to do that good. But if the patient is unable to hold this or he loses the position at the IP joint of the thumb, that would be a positive test result of the anterior interosseous nerve. The Watson test is done to assess for carpal instability, especially at the scaphoid. So I'm going to have the patient in maximum ulnar deviation and slight wrist extension, and then I'm going to palpate the scaphoid with my thumb and push it dorsally, while I'm going to bring the patient into radial deviation and slight flexion. So a positive test result would be a clunk as the scaphoid dislocates. The scapholunate shear test is done to assess for instability at the scapholunate region. So for this test, I find the patient's scaphoid and lunate. So I'm coming down the third metacarpal, finding capitate, and moving proximally to find the lunate. And then I find the scaphoid by coming over the anatomical snuff box, placing my 2 fingers here, and then I will shear between the two. So hypermobility compared to the uninvolved side or reproducing the patient's pain would be considered a positive test result. The lunotriquetral shear test is done to assess for instability at the lunotriquetral region. So I come back to palpate the lunate with my thumb, and then I'm going to come over the pisiform, which is on top of the triquetrum, and then I'm going to create a shear here. So hypermobility compared to the uninvolved side or reproducing the patient's pain would again be considered a positive test result. The Lickman test is done to assess for mid-carpal instability. So the patient will have his arm resting in pronation, and I will palpate the capitate and provide pressure at the dorsal aspect. With the patient starting in radial deviation, I will axial load through the carpus as I move into ulnar deviation. If I can feel the proximal row of carpals sublux with this motion, that would be a positive test result for mid-carpal instability. Another test for suspected carpal instability is the shuck test. So the patient is resting his hand and MCPs and some slight wrist flexion. So I'm going to provide resisted extension distal to the MCP joints. And a positive test result would be reproducing the patient's symptoms or complaints of pain. To perform the CMC grind test, I will first axial load the CMC joint if the patient is having pain at the base of his thumb. So from this loaded position, I am then going to take the metacarpal and do some circumduction in this area. So reproducing the patient's complaints of pain or a feeling of crepitus would be considered a positive test result. The piano key test is done to assess the distal radial ulnar joint. So with the patient's arm resting in pronation, I'm going to place my thumb over the distal ulna and push down. This will create a shear at the distal radial ulnar joint. So reproducing his pain complaints would be positive, but make sure to compare it to the uninvolved side. Next, the distal radial ulnar joint stress test is done to assess the joint integrity. So I'm going to stabilize the distal radius while holding on to the distal ulna and shearing in an anterior-posterior direction. Reproducing the patient's complaints of pain at the joint would be a positive test result. The UCL stress test at the thumb is done to assess for a possible injury here, so I will hold on the CMC joint in about 30 degrees of flexion while stabilizing here and provide a stress at the UCL. Reproducing the patient's plane or excessive motion would be a positive test. Motion beyond 30 degrees would be indicative of a partial tear at the UCL, and make sure to compare this to the uninvolved side. To assess for a TFCC lesion, the ulnar meniscal triquetral shear test can be done by taking my finger and placing it on the patient's pisiform, and then placing my thumb on the distal aspect of the ulna, and I will then create a shear across the TFCC by squeezing here. A positive test result would be reproducing the patient's ulnar-sided complaints of pain. The sit-to-stand test can assess for TFCC problems, so I'm going to have the patient rest his hands against the armrest here, and then push through his hands to try to come up from sitting. Just like that. And I'll have him do it one more time. And reproducing his ulnar-sided complaints of pain would be a positive test result. Another test to assess for problems at the TFCC is called the supination lift test. So with the patient sitting, I'm going to ask him to supinate both arms, and then I'm going to provide a manual resistance to his elbow flexion, as here. And reproducing his pain would be a positive test result, but I can also have him place his hands under the table while his arms are supinated again and ask him to try and like he's going to lift the table up. So reproducing his ulnar-sided complaints of pain would be a positive test result. The ulnar impaction test is another test for assessing the TFCC. So with the patient resting with his elbow flexed, I bring him into ulnar deviation and axial load through the 4th and 5th metacarpals. Reproducing his pain here would be considered a positive test. So from this position, I can perform the TFCC load test by scouring his wrist by moving his wrist into flexion and extension while he is still ulnarly deviated, and I'm applying that axial load through the 4th and 5th metacarpals, and again a positive test result would be reproducing his complaints of pain. The Bonnell-Littler test is done to assess for motion restriction of the fingers by determining if the patient's limitation in his PIP motion is due to intrinsic muscle tightness or if it's a problem at the joint. So with the patient's MCP joint in neutral, I will passively see how much motion he has at his PIP joint. If he is limited, this means I'm unsure if the limitation is due to the joint capsule being tight or due to intrinsic muscle tightness. So if I put the MCP joint into some flexion, and then I reassess PIP joint motion, if the motion increases, then the problem is due to the intrinsic muscles of the hand being tight. But when I put the MCP joint in flexion and PIP joint motion is still limited, this means the joint itself is tight. The Haynes and Coley test can be used to determine the source of DIP motion restriction. So I'm going to bring the PIP joint into extension and then passively see how much motion I can get at his DIP joint. So if motion is limited, I must determine if the limitation is from the joint itself or from the retinacular ligaments. So if I flex the PIP joints and then reassess DIP flexion and flexion increases, this means the original limitation was due to the retinacular ligaments being tight. But if he still has the same amount of DIP motion with PIP flexion, this means the joint capsule itself was tight and limited. The Finkelstein test can be done to assess for a potential de Quervain's problem or inflammation of the first extensor compartment. So I'm going to have the patient cover up his thumb with his other fingers, and I'll passively bring his fist into maximum ulnar deviation. So reproducing his pain across the snuff box area or in the first extensor compartment would be a positive test result. The FDS and FDP tests can be done to determine if a problem with finger flexion is due to the profundus or superficialis muscle. So first, to isolate out for FDS, I have the patient rest with his hand out straight, and I'll block the fingers and allow him to bend his one finger up. So I can assess another finger as well. He's actively flexing the finger, so since profundus is relaxed, I know FDS is intact and firing. So to isolate out for FDP, the only thing that will be a flexor of the DIP joint is the profundus. So I'm going to block everywhere else, and he is able to get active flexion at the DIP joint, indicating an intact profundus muscle. If a patient is having difficulty straightening their fingers out, you can do the integrity of extensor hood test. So with the patient resting with his PIP joint supported and in 90 degrees of flexion, I'll give very light resistance first to all of his fingers, telling him to straighten them out straight, and I can also assess each individual finger. So a positive test result would be an inability of the patient to extend his fingers against my resistance. The Phelan's test is done to assess for carpal tunnel syndrome by having the patient place the backs of his hands together and then maximally bending at his wrist, and he assumes this position for 60 seconds. A positive test result would be reproduction of numbness, tingling, or pain in the patient's median nerve distribution. So another test to assess for carpal tunnel syndrome, if the patient does have the available shoulder range of motion, is called the hand elevation test. I'll have the patient elevate both arms and then bend down at his wrist. I'll have him hold this position for 3 minutes, and a positive test result would be a reproduction of numbness or paresthesia or pain in the median nerve distribution. The carpal tunnel compression test is another test to assess the median nerve for carpal tunnel syndrome. So with the patient resting in supination, I'll take both thumbs, kind of using a dummy thumb, and go right over the median nerve and apply compression for 30 seconds. A positive test result would be reproducing the patient's complaints of median nerve paresthesia or irritation. Another test to assess for carpal tunnel syndrome is the reverse Phelan's test. I'll have the patient put his palms together and then drop down into maximum wrist extension and hold this for up to 60 seconds. A positive test result would be a reproduction of his tingling, paresthesia, or pain in the median nerve. To assess the median nerve at the carpal tunnel, I can do the Tunnell sign. So I'm going to palpate for the median nerve and then do a rapid tap over the nerve, just like that. And a positive test result would be a reproduction of his pain, tingling, or paresthesia distally. The Froment sign test is done to assess for suspected ulnar nerve injury in the hand. So I'm going to take a piece of paper and have the patient hold it between his thumb and the rest of his hand and then resist me pulling it out. So he does that and has a normal response, but a positive test would be if he can't hold the paper without compensating by using his flexor pollicis longus through hyperextending at the MCP and flexion at the IP joint. The Allen test is done to assess the vascular integrity of the hand. I'm going to find the patient's median and ulnar arteries and have him open and close his fist like he's making a pumping motion 5 times. So on the last pump, he will keep his fist closed, and then I will compress at both arteries and have him slowly relax his hand. So I'll first let the ulnar artery go and then see it fill back, which is good. I'll then have him repeat this pumping motion 5 times, holding his fist closed, and then slowly releasing it, and then I'll let go of the median artery and then see the filling return here, which is good, but a positive test result would be a delayed or absent filling return.